I want to thank you all for coming. I think this is our final grand round this season, not ever.
Actually, we have one more. That's where we showcase our creativity. But this is the last time.
This is the last time.
There you go.
I will misspeak several other times today as well. So we're very thankful to have Dr. Gabby Rodriguez, all the way from the wonderful world of Indiana, joining us in 2D today. She actually hung out in Miami for quite some time. She's coming to us. She's a professor in clinical psychology, in the Department of Psychiatry at the School of Medicine. She currently serves as a staff psychologist at Ph.D. and social disorders outpatient clinic at Riley Hospital for Children. She also provides child and adolescent behavioral health services through an integrated care program. She earned her bachelor's from University of Bloomington. Then she hung out down here at FIU, where she earned her PhD in clinical child and adolescent psychology, where she was a Worlds Ahead graduate. She completed her clinical internship at Connecticut at Johns Hopkins University School of Medicine, and then she completed her postdoc at Harvard University. Her research interests include effectiveness and implementation of evidence-based intervention for youth mental health problems within community settings, which is the interest of our IPC, something that we have used. So we're really focusing on implementation, so we wanted to learn more about that, but also kind of some of her perhaps less kind of those experiences been like for her in the process. Her clinical work involves assessment and treatment of ADHD, disruptive behavior disorders, and comorbid disorders using evidence-based treatments. For areas of clinical expertise, shockingly, we have someone that knows something about PCIT. I don't know how that happens. And then modular approach to therapy for children with anxiety, depression, trauma, or chronic problems, which we'll be speaking about in more detail today. Just in terms of some of her stats, she has 14 peer-reviewed pubs and chapters, with I'm sure more on the way, approximately 20 presentations at national conferences, and again, she's done a lot of dissemination and implementation work as relates to MASH, and she's also a new role for her as co-chair of enhancing access to evidence-based mental health and addiction intervention for youth, and she's part of the task force at Indiana with respect to that. So please join me in welcoming
Thank you. Can you guys hear me okay?
Yeah.
Yeah? Okay, great. So as Jason said, today I'm going to be talking with you guys about a flexible approach and modular approach to treatment for children and adolescents. I do not have any conflicts of interest to declare. So my goal really for today is that we will kind of gain an understanding of what Match ADTC is all about, why it was developed, how people can use it in their own practice, and as Jason said, some of the challenges that, some of the lessons learned and challenges that we've had in implementing Match. So let's start with a story. So this is John, and John is a therapist in a community mental health clinic, and he's really excited about using evidence-based treatments with his clients. He is about to do an intake with a 10-year-old boy who he knows from kind of preliminary paperwork is coming in with a previous diagnosis of oppositional defiant disorder. So given that presenting concern, John decides, okay, I'm really into evidence-based practice, so I'm going to pull out Russell Barkley's Defiant Children Manual, which he knows is a behavioral parent training program that has some of the strongest evidence for addressing conduct problems. So everything should be totally good, right? The intake though, John learns that about a year before the intake, his patient witnessed some domestic violence, and he is experiencing some trauma symptoms as a result of that. The other thing he learns during the intake is that many kids with behavior problems, his client is having a hard time fitting in at school, and he's also having some negative thoughts about himself. And John thinks to himself, well, it's really important to me to use evidence-based treatment. That's a value of mine. So I'm just going to pick up another manual, maybe another manual. So he's got a couple now, and he's going to plan to use those manuals to address his individual client's concern. So he gets started with that, and after a few sessions, John learns, you know what, his client has actually always had a fear of dogs, and this didn't really come up before because there weren't too many dogs around, but now the family's new neighbors have 2 big dogs that are pretty much always in the backyard. So now his client is not only not playing in his own backyard anymore, but he is refusing to even walk down his own driveway to get in the car and go to school. And he's still having a hard time in school like he was before, and now is worrying pretty excessively about having to go and face his peers, whom he's having a hard time fitting in with. So, you know, John has made a commitment to himself that he is going to stick with evidence-based practice. So hesitantly, he picks up another few manuals because he's really focused on giving his client the best possible care that he can. So now he just has to figure out how to learn all of these protocols while, you know, doing what clinicians do on a day-to-day basis, seeing clients, sometimes up to 30 clients a week, going to team meetings, going to supervision, you know, all of the things that are kind of day-to-day life of a clinician. So not to mention, too, that the intake that he just completed has a kiddo with a whole different set of presenting concerns. So what do we think John's going to do at this point? Probably this, right? Most likely he's going to give up, and he's going to probably give up on the one he started with too. As you can see, Defiant Children is not part of the package now either. And the thing is that this is one of the many problems that clinicians who are working in the front lines of mental health care often face. And this is part of what led to the work that I'm going to be discussing today. So John's problem is really an example of what has been referred to in the literature as the research to practice gap in mental health, which I'm sure you guys are all keenly aware of. So specifically what that research to practice gap refers to is that psychosocial treatments that are developed usually in university research labs are just not being incorporated into most everyday clinical practice. And we know that this gap is true for adults, but we also know that the gap is even wider for children and adolescents, and it's a really big concern. So this is just a quote from Senator Humphrey, and this is here. I'll let you guys read it. I won't read it to you. But the important thing about this is to know that this gap has been identified as early as 1963. So this was an article that he had in the American Psychologist talking about the importance of building bridges from research to community programs. And he goes on to mention, you know, different areas in which research really needs to be disseminated from, you know, Congress, the federal office buildings, all the way to PTAs and street corners. So really, folks have been working on this problem for over half a century. So this work that started, you know, in the kind of early 60s, I guess you could say, has led to the development of the field of dissemination and implementation science, which really aims to bridge the gap through a number of practice-informed research strategies. What you see here is kind of a diagram talking about dissemination and implementation science. This is from the University of Illinois Chicago website. They have tons of great resources on dissemination and implementation, so it's highly recommended. And they're really part of the team who's kind of leading the work in D&I research. So let's talk a little bit about why this gap is happening, right? So we talked about the story of John, but there's really kind of a lot of other reasons that evidence-based treatments have difficulty being implemented. So some of the limitations of evidence-based treatments that are developed in university research labs have been identified as those contributors, right, to that research to practice gap. So one thing is that most of the treatment protocols that are developed in university research settings tend to be created within highly specialized labs or highly specialized clinics, or both. The other thing is that most treatment protocols tend to be designed to treat only one disorder or a small homogeneous cluster of disorders. And they also typically involve a predetermined sequence of prescribed session content. So it goes session 1, session 2, session 3, and this is kind of the order that everyone needs to go in. And the other thing is that this is getting better, so I think this is great news, but historically, most often these treatment protocols were tested with primarily white and middle or upper class families, so who were the ones kind of accessing specialty care within university settings. So that's great, but that's not what clinical practice looks like most of the time, right? So in most everyday clinical practice, what we actually see is caseload diversity. So most clinicians are not necessarily kind of working just within a behavior problem clinic or just within an anxiety clinic. Most of the time, they carry caseloads where, you know, there are lots of different diagnoses that they're dealing with. Another thing that's important to know is that comorbidity is really the norm. So while the previous university studies tended to focus on kiddos who had one disorder and kind of excluded kiddos who had comorbidity, the fact is that most kids and teens who are referred for treatment present with comorbid disorders. So this is an important thing to keep in mind. Another thing is that for clinically referred use, most of the time the problems that are happening and their treatment needs really shift during treatment. So there's a lot of flux in what's kind of the biggest concern at different times. And finally, we know that our world is diverse, and the kids who are referred to clinics come from lots of different racial, ethnic, economic, religious, you know, sexual orientation, all different kinds of backgrounds. So it's different, right? So when we look at, you know, the caseload diversity, comorbidity, flux, and diversity, it looks really different in everyday clinical practice than it tends to look in our university research studies. So in response to this challenge, the MacArthur Foundation created the Research Network on Youth Mental Health. So this was a group of researchers and clinicians who had expertise in things like organizational characteristics of clinics. They had expertise in things like the roles that family advocacy groups play in influencing treatment, as well as treatment decision-making guidance. So their main project was called the Child Steps Initiative. So that stands for the Child System and Treatment Enhancement Project. So, you know, in psychology, we always need a good acronym. So the Child Steps Initiative was really designed to do three things. So one was to gather information on what were the clinic settings where children were already being treated and what were the characteristics of the clinicians who were already providing that treatment. The second thing they wanted to do was to design new and integrative methods for implementing evidence-based practice. And finally, to develop tools that could help clinicians make very sound decisions during treatment. So kind of as part of the research network and as part of the Child Steps project, network members John Weiss and Bruce Sharpita developed MATCH, which is the modular approach to therapy for children with anxiety, depression, trauma, or conduct problems. So in total, it's MATCH ADTC, but oftentimes people just kind of drop the ADTC and refer to it as MATCH. So this approach really allows clinicians to tailor their treatment to the specific needs of their patients while still using evidence-based methodology. So MATCH was developed by identifying some of the treatment procedures that were used in evidence-based treatments for 4 of these common youth mental health problems: anxiety, depression, trauma, and conduct. And what they did was they evaluated over 100 randomized control trials to look at what were the specific treatment strategies that were evidence-based in those successful clinical trials. And what they came up with after evaluating all of those RCTs were specific treatment procedures. So for anxiety, they use cognitive behavior therapy for anxiety. And so you will notice if you look at, let's see if I can get the laser pointer here. So if you look at these yellow circles, ignore the purple ones for now, you will notice that there are some of the things that you may be familiar with from other cognitive behavior therapy protocols for anxiety. So for example, providing psychoeducation to the parent and child, developing a fear ladder or exposure hierarchy, doing exposure, which we call practicing and MATCH, and other kind of related things. The next thing you'll notice is that there are a couple of purple circles, and those purple circles are actually the trauma modules that are included in MATCH, which I'll talk about a little bit later. So the next thing for depression, they again looked at those randomized trials studying effective therapy for depression and found that cognitive behavior strategies were most effective. So you will notice here some things that are common to typical CBT for depression, like, again, psychoeducation, problem solving, activity selection, which is the match name for behavioral activation, relaxation, and thought challenging. And finally, when they looked at the randomized control trials for conduct problems, they found that behavioral parent training was the most effective strategy. So each of these modules includes some of the treatment strategies that are common to behavioral parent training programs. So you'll notice one-on-one time, praise, active ignoring, timeout. So all of these 33 modules together result in the Match ADTC treatment manual. These are all the modules that can be found there. So a couple of things that I want to say about Match. Some things that Match is and some things that Match isn't. So let's start with some things that Match is. So Match is flexible. It's flexible in that it uses data from each individual case to decide what's going to be the initial treatment focus and also what's going to be the module that we do next. And it's also multifaceted. So it is designed to address those 4 disorders that are very commonly seen in outpatient treatment. Now, what is it not? And this one is one that comes up a lot, especially when we're doing training. So Match is not a free-for-all. It doesn't mean you just, have those 33 modules, you just grab one and move on. There are specific flowcharts that we'll go over together in a second that guide the decision-making about which modules to do next within each of the 4 target problem domains. And it is also not without focus. So it may seem like it because there are so many different modules available, but a target diagnosis is always identified in the beginning and it remains the focus unless the data justify a shift to a different problem area. So a couple of other comments. So what makes Match different? The flexible use of modules is probably the biggest thing that makes a difference, where each of those modules is either a behavioral principle or a skill. And all of these are similar to existing evidence-based programs. And one important thing to know is that the only thing that's copyrighted is the use of the actual manual and the worksheets that are included in there. But those behavioral principles are not copyrighted, right? Those are things that we can find across lots of different treatment protocols. So let's look at the main flow chart. So this is what when you're using the Match manual, this is kind of the first place that you start. And you start here so that you can select the primary problem or the one you're going to start working on first. And if the problem does not fit within these areas, then the recommendation is that another treatment should be used. So for example, if a youth is presenting with an eating disorder as the primary concern, and there are other evidence-based programs that would be considered more effective to be used, and so then that would be the recommendation. So why do we need to determine what the initial treatment protocol is going to be? So first is because we need to have a hypothesis about which problem is paramount, which problem is causing the most impairment for each individual kiddo. And we also need to use it so that we can measure improvement across treatment. If we don't kind of have a focus and a direction, then it's hard to figure out whether things are getting better or not. So how we do this is that we use the assessment information to decide which one of these problem areas we're going to start with. And usually that's done through either or, so standardized assessments like the child behavior checklist or use self-report or diagnostic interviews, or you can use both. So then once you have the assessment information, then you develop, as usual, your initial case conceptualization and identify what the top problems are. And there's actually on the Harvard website, I just noticed recently on the Dr. Wise's lab website, a measure of top problems that is now publicly available. So I can talk about that a little bit more towards the end. But it's one of the things that happens throughout Match is that both the child and the parent, or both parents, identify what their 3 top problems are, and that measure is something we use throughout treatment to see how things are improving. So we revise, we conduct assessments throughout. That's one of the big components of this. And so we revise what the direction of treatment is continually and use that as a touchstone for treatment. So let's say that we've already done our assessment, we've gone through the main flow chart, and now we are moving on to the actual problem areas. So let's look at the anxiety protocol. So here in the beginning, I know this looks like a lot, but I really want you to focus your attention on this kind of top half. So above where my laser pointer is drawing an imaginary line, maybe I'll draw a real line next time. Just focus on those top modules there. So you'll notice that anxiety is all in the orange color. So everything is color coded to make things a little bit easier so you can determine which protocol each module is in. So you'll notice here that the flowchart directs a therapist to start with a getting acquainted session and moving on to developing a fear hierarchy or fear ladder, then conducting some psychoeducation for the parent and the child. And once those are completed, and one thing I'll mention is that this does not need to be 4 sessions. So one thing we'll talk about later is that oftentimes a module can take 1 session, 4 sessions, or really no specific limit. It's more important that the family kind of get all of the information that they need before moving on. And so sometimes that's the case, that it takes a little bit longer. So once these 4 modules are completed in the anxiety protocol, we come to a decision point. And we need to determine whether this particular kiddo that we're working with is ready to practice. So remember, that's what we call exposure and match. And if the answer is yes, wonderful, we move on to the practicing module, which very often takes several sessions. And if the answer is no, then we move down to the bottom of the chart. So this will be the case for all 4 protocols. The kind of initial treatment plan is up here. And then if we encounter interference, that's when we move on to kind of the rest of the modules. So one example may be that this kiddo is having a difficult time with practicing and the therapist thinks they may not be quite ready yet because they're having a lot of anxious thoughts. They're kind of doing a lot of worrying. So that may be a situation where a therapist brings in cognitive stop. So this is our thought stopping skill. So let's say then the therapist completes the thought stopping, kids' worry thoughts get better, we come back up to this decision point, is kiddo ready to practice? Yes, excellent. We move on to practicing. Then we get towards the end of treatment. We try to determine, are the gains complete? Are the goals that we set out to complete in the beginning where we want them to be? Then we talk a little bit about maintenance, and then we wrap things up. So similarly, in the depression protocol, you'll notice that all of the kind of prescribed treatment, if you will, is up at the top. And then the interference practices are listed here at the bottom. So for this, for every kiddo, we'll start with a getting acquainted session, psychoeducation. Then at that point, if kiddos are able to proceed, then we will start with each of these modules in this order. In this case, and in all cases actually for all 4 protocols, the skills are in the order that they were found to be most effective. This is a little different in conduct, and I'll get to that in a second. But problem solving is listed first because it's actually the individual treatment strategy that has the most evidence as far as treatment of depression for kids. So that's why it's included first, followed by behavioral activation, followed by 2 types of relaxation, et cetera, et cetera. And then similarly here at the end, if gains are complete, then we can talk about plans for coping. And we do a wrap-up session, which is pulled from the anxiety protocol because they're really very similar. So this is the traumatic stress module. So as I mentioned before, the trauma modules are in purple. So really most of the traumatic stress modules come from the anxiety protocol. So you'll notice that we first do getting acquainted, a fear ladder, psychoeducation. Then we move on to the first trauma-specific module, which is safety planning. That can sometimes move to the end, as it mentions down below, if there are not kind of urgent safety concerns. Then we teach some relaxation. And if kiddos are at this point ready to work on their trauma narrative, we move on to the trauma narrative. So I can't see you guys, but can you kind of shout out how many of you are familiar with trauma-focused CBT? Yeah. Okay. So one thing that a lot of folks, when we've done training, so in the trainings in Connecticut, for example, the Connecticut clinicians had recently been through a learning collaborative in trauma-focused CBT. So they had lots of questions in this traumatic stress protocol about why these things are in the order that they are. So I think the main thing that you'll probably notice is that in TFCBT, parenting skills and child coping skills are kind of included first before kids then get to the trauma narrative. Whereas here, they're really only included on an as-needed basis. So it's not really part of the typical sequence. So definitely if kids are not ready to move on to the trauma narrative, the parenting skills can be brought in as well as the child coping skills, but it's not necessary. And the thought is that the trauma narrative is thought to be, based on the research, the most evidence-based component as far as treating trauma. So the match kind of way is to introduce those most evidence-based components as early as possible in treatment. And we can discuss that later because I'm sure people will have thoughts. All right, so the last protocol is the conduct protocol. So in this situation, we kind of start out with engaging parents, doing some psychoeducation. And if we're able to proceed, we move on then to the specific modules. So as you guys probably know, it's very important that when we do these parenting skills, they happen in a specific order. So this is the one protocol where things are a little bit different. So typically you want to stick with, starting with praise and one-on-one time, then moving on to active ignoring, then effective instructions, because as we know, those skills all build on each other, right? And it's really important that kiddos have that, kiddos and parents have that very solid relationship foundation before we move on to more of the discipline skills. So kind of keeping with that, in this case, the recommendation is to complete these in that specific sequence rather than kind of pulling modules in or out as needed. And similarly, we can bring in other skills as needed. So one that happens pretty often, I would say the one I do the most is I kind of take a pause in conduct problems to teach kids some problem solving or some relaxation. Usually problem solving is related to situations at school, and usually relaxation is, they kind of can't calm down, and so ignoring can be very helpful, and it can be even more helpful if kids have some strategies to cope with their own distress. The other thing I want to mention is that rewards, which is up here, is a module that we use often across all of the different protocols. So we use it often in depression, anxiety, and traumatic stress. So you may be wondering, what is the evidence for MATCH? So in 2012, the folks who developed MATCH published their randomized effectiveness trial, and they screened 500 youths and randomized 200 youths were allocated to 96 therapists who were randomized. So this is kind of a unique situation where we can't randomize the youth themselves. It has to be the therapist. And youth were ages 7 through 13, and their primary disorder or referral problem was either anxiety, depression, or disruptive conduct problems. And the three conditions were the modular approach, so MATCH, standard care, which I'll define in a second, or usual care, which means in this situation, whatever care the clinicians were already providing to their patients or clients. So the standard condition was composed of 3 established evidence-based treatments. So they used Coping CAT, that you guys may all be familiar with, as the cognitive behavior therapy for anxiety. This one's usually 16 through 20 sessions, typically. They used PASCET, which is the primary and secondary control enhancement training program, and it is a cognitive behavior therapy for depression. And that one tends to be 10 to 15 sessions. And finally, Defiant Children, which we've already talked about, is behavioral parent training program for disruptive behavior that contains 10 steps. So this was the standard condition. So in the final analyses for this study, they had 174 youths, and they were primarily boys, mostly white and multi-ethnic. Those were the 2 biggest endorsed ethnicities. And most of the families were from lower income backgrounds. The average kiddo was about 10 and a half years old, and a little over half, so 53% of the families were single parent households. And these studies were conducted, so there was one arm in Boston and one arm in Honolulu. So what is the evidence? So when comparing the modular approach, MATCH, versus usual care, using weekly measurements, so looking at those top problems and other standardized measures, They conducted a mixed effects regression analysis that found significantly steeper trajectories of improvement, so they got better a lot faster in the modular condition compared to the usual care and compared to the standard treatment. So the effect size here was 0.59. Very proud of my little arrow thing. So only took like 2 hours, don't worry about it. And then they compared the modular and standard care approach, and the effect size here was 0.71. So looking at effect sizes is helpful, but let's also look at what their actual diagnoses look like. So prior to treatment, there were no significant differences in diagnosis. But what was found at the end of treatment was that the youths who were in the modular treatment group had significantly fewer diagnoses than the youth in usual care. There were no significant differences in diagnoses between standard care and usual care, or between the modular and standard care. So I think that's something that's important to keep in mind. So taken together, what the authors concluded was that these findings support the effectiveness of the modular approach, which is, as we talked about before, designed to address the needs of clinicians who carry diagnostically diverse caseloads, and designed to address the comorbidity and flux that are common among youths that are referred for mental health treatment. So next, I want to talk to you guys a little bit more about the different studies that were going on while I was working as part of the lab. And we'll spend a little bit of time on each of these. So another study following the kind of original MATCH study started in Maine in 2008. And it was comparing MATCH to usual care only, so no longer comparing to the standard care, for kids 6 to 15. So they expanded down a little bit from 7 to 6. With anxiety, depression, post-traumatic stress, and conduct problems. So in this case, they included all 4 of the primary diagnoses. So that study is currently in the long-term follow-up phase. And one thing that they're doing in Maine is that they are examining sustainability. So this is part of what's important when we kind of get to this stage of work in dissemination and implementation is one kind of randomized effectiveness trial is great, but we really need to know how is this going to look years later once the research team is no longer involved. So part of what they're doing in the Maine sustainability study is looking at what ongoing supervision, the results of ongoing supervision when it is delivered by existing clinic supervisors compared to when it's delivered by study personnel. So basically they kind of did an initial MATCH training in that study. Following the initial MATCH training, some of the supervisors were selected to attend an additional kind of supervisors training. And these were kind of monthly over a few different months. And then those supervisors who were already part of the clinic started some of the clinicians were randomized to receive MATCH supervision from those existing clinic supervisors, and some of the clinicians were randomized to receive supervision from our study personnel. And that's an ongoing study comparing what that looks like. We'll get into kind of lessons learned here in a second. So the next project that's ongoing is examining consultation. So it's a little similar to sustainability, but it's really a randomized controlled trial examining the effects of expert consultation versus training only. So this is the Connecticut study. And so what we did in the Connecticut study was that clinicians came and we went to the clinicians because we did the trainings in Connecticut. Clinicians received a 6-day MATCH training that was split over 3 separate months, so they came for 2 days at a time. And then some clinicians were randomized to continue with expert consultation, and some clinicians at the end of the training were kind of set on their own, and they continued to receive their regular supervision as part of their clinic, but there was no MATCH-specific supervision. And then the other clinicians, that's where we were involved as the postdoc fellows. We were providing expert consultation. So what that looked like is that clinicians would record their sessions, and we would listen to a sampling of their sessions, and then we would provide consultation for those specific cases. This was typically done in a group format, so there would be a few different clinicians from one clinic on the phone call with the expert consultant, and usually one clinician, in addition to the case, the audio tape review, one of the clinicians needed to do a case presentation and then receive feedback from everybody on the call first and then the expert consultant. And the idea there is that we were hoping that, to do kind of a stepwise approach, if you will, or so that initially the expert consultant would provide a lot of the information and a lot of the consultation, and then that consultant would kind of gradually step back so that at the end of the year-long consultation series, it really was happening primarily amongst staff themselves. And then the third study that was ongoing during my time there, and I believe is still ongoing, is a school-based study. So this was a randomized controlled trial comparing match versus usual school-based therapy. And what was interesting, I think, and kind of innovative about this is that we were looking not only at the students' mental health outcomes, but also their school-related outcomes and academic outcomes. So things like attendance, things like their performance on standardized tests, GPA, things like that. And the thought there is that, oftentimes we can get people, and I think this is improving, we can get people excited about improving mental health, but ultimately in an academic setting or educational setting, the things that really are going to make people get the most excited are probably going to be academic and school-related outcomes. So the thought is that if we can show that having match improves those outcomes, we can get better buy-in for school districts implementing something like this. So in that study, things were a little bit different. So clinicians, again, were randomized to either continue their usual practice or receive match training. And then in this case, we actually went out to the schools and we did individual supervision or match consultation, really, with each of the clinicians. There were fewer clinicians in this study, so we actually listened to all of their sessions on a weekly basis and then came back and provided some feedback, talked about, kind of how to prepare for next week's sessions and things like that. So I want to talk a little bit about some lessons learned here. So one thing that we learned, and I'll start with the school-based study, is that outpatient therapy is very different than the school-based therapy that most students receive. So one thing is that while in an outpatient setting, you may be able to get through 10, 12, maybe even 15 modules if it's appropriate for the protocol. In the school-based setting, we actually most of the time had to kind of choose two. And part of the reason for that was that school-based clinicians really maybe got the students for like 10 to 15 minutes a week, and it wasn't every week, and sometimes it was kind of unpredictable when it was going to be. It was kind of whenever the clinicians had some availability. And so we really had to spend more time in the beginning figuring out, our case consultation and what we thought was going to be, where were we going to get the biggest bang for our buck. So that tended to be on average probably, anecdotally speaking, for most of our kids, problem solving was probably one of the biggest ones that we did. And also a little bit of the coping skills, relaxation. The other thing that was challenging in the school setting was that we couldn't really get parents to come to do the conduct protocol. So most of the services really in the school setting tended to be focused on either the depression protocol or the anxiety protocol, less so on the trauma protocol, and definitely not as much on the conduct. So those were some of the challenges that we faced there. The consultation study, I think, actually is going really well. Some of the challenges that we face there is that, well, a phone call can be helpful, but it can also, especially when comparing it to our face-to-face individual consultation that we had in the school study, sometimes the phone call didn't quite feel like enough. And so sometimes, we discussed the case and we spent a good amount of time talking about things that maybe belonged a little more in regular supervision and less so in matched consultation, right? Because that's an important difference to draw in that every clinician is still going to have their traditional supervision, and clinics have their own policies and procedures. So it could sometimes be challenging to get down to the kind of match consultation component. Another thing is that one thing that we noticed is that providing the flowcharts can be helpful because it gives a guide. Sometimes what we found was that clinicians were kind of sticking to it a little bit too rigidly, and they weren't thinking as flexibly as we would want them to. And so it was an interesting kind of situation in that match is designed to be very flexible. but we wanted to, whoever, John and Bruce wanted to provide a guide, and so it was a little bit of a challenge of how much do you stick to the flow chart, how flexible can you be, and at which point are you then no longer providing an evidence-based treatment. So I think that's kind of an ongoing challenge when you're consulting on something like this. And then I think, on the sustainability study, I was less involved with that one, but some of the things that I heard were things about, well, the supervisors who were part of the clinic already and then became MASH supervisors, I think probably needed a little bit more support. And so one thing that we wondered is whether it may be that those are the ones that need to get ongoing consultation with the study personnel so that then they can kind of feel more comfortable or feel stronger when they're providing supervision to the other clinicians, right? So we wondered if maybe kind of a tiered or kind of hierarchical approach, I guess, would be more helpful. So I'm guessing that's a direction for the future. So I want to make sure that we leave enough time for questions. So I'm going to move on to kind of wrap things up, but I want to let you guys know that we can always come back to this slide because I think that this is likely where we'll get a few different questions. So kind of the take-home message here for MATCH is that it is a flexible, modular approach to therapy. It addresses common clinician concerns that come up in everyday practice. It is appropriate for kiddos who are ages 16 to 15 with anxiety, depression, trauma, or conduct. It is possible to modify a little bit down and modify a little bit up as far as age. Usually if we do that, it's related to kind of changing what the worksheets look like and things like that. There's not a lot of 16 and 17-year-olds who like to see like cool cartoons on their worksheets, whereas a 10-year-old might love that. So some of that needs to happen, but really the principles are the same. So it can be used with kids who are just a bit younger and a bit older. And finally, MATCH can be used by any licensed mental health professional. So anybody who is licensed to practice can just pick up MATCH and start using it. There are trainings available, but it is not, it's different than other programs like parent-child interaction therapy, for example. There is no MATCH certification, and so anybody can kind of pick it up and use it. And finally, it is part of a series of efforts that we've talked about a little bit, designed to bridge the research to practice gap in youth mental health. Hopefully this is where we're going. So I wanted to acknowledge Dr. Weiss and the Lab for Youth Mental Health. So all these folks here were involved in those last studies that I talked about. And then I want to give us some time for questions.
Good. Unshare screen, maybe we'll give you a few.
I can't hear you, I'm sorry. What?
I said if you want to unshare your screen, maybe we'll be able to show the other people.
Okay. Is that better?
I'll change the cam so you do the stallions. We have some other.
Oh, now I'm like on the whole TV. Oh, okay, I can see you guys there.
I'll just keep on moving this over and over again. Okay. All right, so questions that people have, and I know there's people that are online as well, so if you have questions, feel free to jump in and ask any questions that you might have. I'll start the questions since everyone wants to be nice and quiet. So one of the things that just kind of popped into my, and I think this is helpful, is it brought up this idea of the need for organizational support in order for things to actually move forward. And so one, wondering if you could comment on some of the other aspects of just kind of, not just at the therapist level, but more from like at an agency or supervisor level, some of the things in terms of whether it's, even if you weren't directly working on that, but you know, some of the school stuff or any of the implementation work where you've seen, because you know, here at Mailman, people are trying to disseminate and implement a wide variety of interventions. They're not all behavioral health in nature, but probably some common threads in terms of organizational support that's needed to kind of make sure that things are implemented well, and then that it increases the likelihood of sustainability. Just because we know that a lot of times, especially behavioral health, when you train them to do something really well, and then they get certified in whatever that is, then they're able to like disappear and go get a higher paying job someplace else, and then like, what do you do after you lose them? So.
Yeah, I wish I had answers for you there. We are struggling with this right now in Indiana quite a bit. But I'll say a little bit about what the experience was like, especially in Connecticut. So I think Connecticut was actually a really great example of kind of how this can be done on a larger scale. One of the benefits of Connecticut is that it's really small. So kind of just look, everything is kind of local in the sense that it's drivable. Pretty much across the state. So one thing that happened in Connecticut is that in response to the Newtown shooting, there was a kind of statewide effort to just work on youth mental health. And so they did a bunch of different things, but it started out with the legislature requiring that they kind of develop this group of people who needed to kind of examine what were the things that were being done and what could be improved. And that led to a lot of different things, but one of the things that led to was a series of learning collaboratives, and the state really focusing on evidence-based practice and providing the resources for these things to happen. So I guess I would say as it really started at the state level and it kind of grew from there. So the study that we were working on was actually funded by the Connecticut Department of Children and Families. They were the primary funders. And then we were working with a CHDI, which I believe is I forget what it stands for. Connecticut, yeah, I don't remember, but CHDI, we talked about it a lot in the acronym format. But basically CHDI was kind of charged with leading the way on getting all of these learning collaboratives happening and working with the researchers and the people who were coming in to implement them. So I think part of the reason that this was effective in Connecticut is, as Jason was alluding to, that there was a lot of organizational support. So clinicians were paid to take those 6 total days off in order to attend training. Oftentimes it seemed kind of from the outside looking in, it seemed almost like a team building activity. So the clinicians and their supervisor would come and participate in training together. So it was a little bit of both, I guess. And then there was also support for participating in the consultation calls. There was support for the supervisors attending those additional supervisor trainings. And this is something that just kind of became part of the mental health system in Connecticut. So as we were, meeting with clinicians and talking to them about MASH, that was honestly one of the ways in which I learned much about what they'd been through, because they had mentioned going through a TFCBT learning collaborative, an ARC learning collaborative. And so it really was just kind of part of the culture at that point in Connecticut, developing those things. So I would say that, from what I've seen in that situation, that top-down support is really kind of what it takes. Unfortunately, I think that's a lot harder to do in larger states and in primarily rural states. So in Indiana, we are struggling with, kind of a lower workforce. We're struggling with the fact that, we have kind of a population center in Indianapolis, but the majority of the rest of the state is really rural. And so I think it's something that was done well there. And I think we're still figuring out how it can be done or replicated in other places.
Other questions that people have? Y'all are acting like it's Friday before Memorial Day weekend. All right, I have another question then. Fully loaded. I will keep us here to 1:30.
I have a question.
Go ahead, Anthony.
I really love this presentation because I work in a pediatric mobile clinic. Well, I'm still part of that pediatric mobile clinic in my heart. So they provide mental health services, a lot of screenings, and some brief interventions in the community while they're there for primary care. So it's integrated into primary care. So something like this could be modular, 2 sessions, almost like the school-based, right? 2 sessions, maybe 3. That's the tops. people will go back to this clinic because they have to miss school, they have to miss work, the parents to come. So this would be an excellent model to try in that setting. But I'm just concerned about, for example, the trauma. I mean, we're learning trauma-focused CBT. We're doing it we have some trainings, we have seen some cases. So to me, the narrative I think is so important, but also restructuring that narrative is also very important. So that's almost like an optional in this module. So I'm like, what about the problem solving and restructuring the narrative and the problematic thoughts and coming up with new thoughts and integrating that into a new narrative? That's not a priority in this model. So I don't know. I'm like kind of skeptic. Like, that's the kind of the meat of trauma-focused CBT. So I don't know. What do you say?
So I've heard that before. So there are two kind of parts. So let me address the first part first. So it's interesting you mentioned that actually, because now, since I started this job last year, I've been working in an integrated care clinic, so in a primary care setting, which is something I had never done before, and I was like, I don't know what I'm supposed to do. So I kind of turned to Match because for the same reasons you mentioned, right? So I can, I don't know how many times I'm going to see you. I think, we usually have shorter sessions, tends to be lower acuity. So in some ways that can be helpful. So, I can introduce problem solving and check in with you another time. And at least that's kind of something, right? And so in that way, it feels like in the limited setting that I'm in, I'm still doing something that I know to be based on evidence, and I know it's going to make a difference more than maybe some other things. So I think that is probably a direction this will go in the future, is figuring out whether this is a model that can be used in integrated care. I'm using it clinically. I'm not doing any research on it right now, but I definitely can see that would be a future direction. The second part is, you're absolutely right. So one thing is that the trauma narrative module does include, so first it is building the trauma narrative, and then as part of that trauma narrative module, you do go back and do that restructuring of the module. The thought challenging skill, which is the cognitive blue, is kind of separate. So that's really part of the depression module, and it's just general thought challenging, not related to a trauma narrative. So it is part of it, and I think you're absolutely right. That's a critical component. What I've heard from folks who have been trained in Match and who have been trained in CBT or TFCBT is that they use TFCBT most often, right? So if that's the main concern, that is what they would use. And I would say that that's what I would recommend too, kind of not what I would do in my own practice, unless a kiddo had really significant comorbidities, in which case I would think it might be helpful to have the opportunity to bring in some of the other modules. But yeah, I think you're absolutely right there on the TFCBT component.
Just give one final statement that kind of goes along with what you said about the school-based practice about, hey, it's maybe 15 and 20 minutes every other week, and kind of speaking to NIE about pediatric mobile clinic of, hey, we only get a couple times. There's definitely this shift in the field, and this is for the next generation of trainees, hopefully to figure this out for us, is that it used to be we do things to fidelity to the established model or nothing, and we then don't offer. So if you can't commit to this, then we're not going to offer. So that's where, you have that gap between research and practice. Now people are starting to realize, like, okay, yeah, like they're never going to attend 10 sessions or 18 sessions. And they're beginning to look a little bit closer about, well, how many sessions on average is someone willing to actually attend? And then how can we fit our existing evidence base to try and provide whatever we can within the time that is allowed for that location, format, or treatment modality, just so that if they can't get everything, that they're at least getting some things that are hopefully moving the needle. I think that as we think about dissemination and implementation, we're definitely moving in that direction, where there isn't just this firm, brick wall which says, you do it my way or no way. It's people are finally moving towards, all right, well, if you can only do 4 sessions, then we have to figure out how to make this the most impactful 4 sessions ever, as related to whatever the construct is. So if y'all can figure that out by next week, that would be. We have one last question.
One last comment / question. So a few of us here are not mental health providers. We are, so you mentioned about an integrated clinic where you participate and work in. So I guess my comment, more so than a question, is how does that information get, implemented? Or we can't implement the match program because we're not mental health providers. So we are physical therapists, but we'll see kids with these behavioral issues. And so, of course, how can that information that you're working on be disseminated for the other health professionals working with the children? And I think that is a little bit of a gap that I see as a provider myself, that I may not have some of the strategies in place that you all are trying to implement with your the children during your sessions. So maybe that can also fill in that little gap where they're only coming for 3 or 4 sessions, but with the other health providers, some of the strategies may be incorporated. Just like I said, it's more of a comment than a question.
Yeah, I mean, I agree with you completely. And in our integrated care program, we have lots of folks from, it's really multidisciplinary. And so we often have that conversation. It's like, oh, like if I just know this, like what can I do? So I think that kind of all of us communicating with each other about these types of strategies can be super helpful, so that, as you said, right, if they're seeing their pediatrician next week, the pediatrician is also talking about, hey, one time is super important. Let's make sure we're catching your kiddo when they're being good. They're hearing that they're hearing it with us. If they're hearing those things kind of across the board, I think we're really maximizing the care, right? So I think it speaks to the importance of like multidisciplinary care and all of us sharing this types of knowledge with each other.
Yeah, I think that speaks to there's trauma-informed care, so it's kind of teaching non-behavioral health professionals kind of how to interact with people that may have been impacted by stress. There's now like a care model that's more about like how to have just positive interactions with children and families. And I mean, I think the other part, I may be on the minority as it relates to this, is primary care physicians can do behavioral health screenings, and I think other non-traditional people could be doing that behavioral health screening and then bringing people to services. So I think that's another avenue. And as Gabby was saying, kind of that team communication, team documentation with respect to that. Warm handoffs, especially if you're working with them in the same number. So not just saying, hey, call this number, but like walking them over to whoever that person is, that increases the likelihood that someone's actually willing to follow up with whatever that subsequent service is. So, all right, I know we were past 1, but thank you all. Thank you again, Gabby, for giving us one talk and giving us a lot to think about. And everybody have a great Memorial Day weekend.
Thank you.
Bye, guys.
Bye.